PMR is an inflammatory syndrome of older individuals characterized by pain and stiffness in the proximal muscles of the shoulder, neck, and/or pelvic girdle in the absence of objective weakness. Constitutional symptoms are common 33%–50% of patients. The core manifestations include patient age is greater than or equal to 50 years. Symmetric shoulder girdle aching for is greater than or equal to 2 weeks. ESR greater than 40 mm/h and/or elevated C-reactive protein, CRP. Morning stiffness greater than 45 minutes. Bilateral hip pain or limited range of motion. Absence of rheumatoid factor, RF, and antibodies to citrullinated antigens, ACPAs. Rapid response to corticosteroids, prednisone 20 mg daily, within a week. Exclusion of other diagnoses except GCA. PMR is the second most common autoimmune syndrome, after rheumatoid arthritis, RA, with a lifetime risk of 2.4% for women and 1.7% for men. PMR rarely affects those aged less than 50 years and becomes more common with increasing age. Most patients are aged greater than 60 years, mean age of onset approximately 70 years. Women are affected twice as often as men. PMR, like GCA, largely affects white patients and is uncommon in Black, Hispanic, Asian, and Native American individuals. The cause of PMR is unknown. Clues to the diagnosis are provided by the epidemiology of the disease. The higher prevalence in certain populations has suggested a genetic predisposition. An association with HLA-DR4 has been reported. One animal model suggests that both PMR and GCA start with the activation of dendritic cells at the adventitia media border of the large vessels, resulting in the production of IL-1 and IL-6, causing suppression of T regulatory cells and an increased Th17 response. Unlike GCA, patients with PMR do not recruit T cells capable of producing interferon gamma, IFN gamma. Without IFN gamma to stimulate macrophages, the arterial inflammation characteristic of GCA does not develop. Interestingly, a PMR-like illness has occurred in patients receiving immune checkpoint inhibitors for cancer treatment. Unfortunately, PMR is still a diagnosis of exclusion and is based on the patient's clinical presentation and elevated inflammatory markers. Recently, experts from the ACR and EULAR have established provisional classification criteria by using a point system to help in research studies. All patients were required to have the first 3 criteria. A. Age is greater than or equal to 50 years. B. Bilateral shoulder discomfort. C. Abnormal ESR or CRP. The points system applies to the presence of morning stiffness, 2 points, hip pain, 1 point, absence of RF, ACPA, 2 points, and absence of other joint pain, 1 point. The diagnostic accuracy of the required 3 criteria plus at least 4 points of the scored criteria yielded a sensitivity of 68% and specificity of 78%. Addition of shoulder ultrasound looking for bursitis only marginally increases the diagnostic accuracy. The most characteristic laboratory finding An elevated ESR, often greater than 100 mm per hour, and an elevated CRP are the characteristic laboratory findings. PMR may occasionally, 7%, occur with a normal or only mildly elevated ESR, less than 40 mm per hour, but in those patients, the CRP is usually elevated. ACR, EULAR Expert Panel Recommendation for treating PMR. A single daily dose of 12.5 to 25 mg prednisone or equivalent dose of another GC is the initial treatment of PMR using the minimum effective individualized duration, or intramuscular methylprednisolone 120 mg every 3 weeks as an alternative to oral prednisone, and early utilization of methotrexate, MTX, 7.5 to 10 mg per week in addition to GCs, particularly in patients who are unable to adequately taper GC or who are at significant risk for GC-related adverse events, e.g., diabetes mellitus and osteoporosis. Note that other studies have used MTX doses up to 20 mg per week. Individualized exercise programs aimed at maintenance of muscle mass and function and reducing risk of falls, especially frail older patients on long-term steroids. The panel strongly recommends against tumor necrosis factor antagonists and Chinese herbal supplements. Points. 1. Polymyalgia rheumatica, PMR, is a common inflammatory disorder in the elderly. 2. Patients present with subacute onset of severe pain and stiffness in proximal limbs without objective weakness, associated with a high erythrocyte sedimentation rate, ESR. 3. PMR may precede or coincide with the diagnosis of giant cell arteritis, GCA, in a significant number of patients. 4. Patients should respond dramatically within a week of initiation of 20 mg per day of prednisone. 5. The presence of fever, failure to respond to prednisone clinically, and/or persistently high ESR on therapy suggests the need for further evaluation to rule out GCA or another diagnosis, e.g., malignancy or infection. 6. PMR treatment often lasts as greater than or equal to 2 years and relapses are frequent.